right, guys, so welcome back. So we just finished up with talking about the craniocervical disruption, and we talked about some of the cerebrospinal fluid flow disruption. Now I want to dive into the jugular vein specifically. So here's the difference. There's the flow pattern inside the brain and down the spinal cord, right? It naturally will continue to flow. It's pressurized through the beat of your heart, so it does have a pulse to it. It's gentle, but if there is any sort of aberrant surface that it has to pass over or through, it will become more turbulent. That's all on the inside. Now what we're going to be talking about is the ability for the cerebrospinal fluid to get out of the brain once it's resorbed. Now, this is really critical because in order for the brain to stay clean and the pressure regulation inside the brain to be normal, you have to be able to allow the cerebrospinal fluid to pass through into the central sagittal sinus, where it collects not only the fluid, but the waste that it's accumulating as well, and has to get all the way out. So just like we talked about, it's plumbing rules. We're dealing with basic plumbing. But the plumbing goes all the way to the heart. Okay, the plumbing from the brain ends in the heart. So right now we're going to be talking about jugular vein blockage. And just so you can see on the bottom of the slides is the piece of this cascade that we're dealing with, just as a reference as we go through. So the atlas bone sits right under the skull. What we're doing is taking a top-down look at the atlas bone. And so you have your carotid arteries, which sit a little more medial, and then the jugular veins, which sit right in front of the transverse foramen. And in this top-down view, you can also see the transverse process. You can see the transverse foramen where the vertebral arteries are coming in. They take a hard right turn and they actually puncture through the dura mater and go into the central spinal canal. The spinal canal, and they actually start to feed blood to the brainstem, the inferior cerebellum, and the posterior portion of the brain. Now, what we're going to be referencing right here is the jugular veins. So what's really important to understand is the jugular veins, when they sit right in front of the atlas bone, right in front of the transverse process is the styloid process. Different people have different length styloid processes. I don't have it imaged here, but there's basically a narrow space for this blood vessel to go through. So if the upper cervical spine does get misaligned, what it can do is compress one side of the jugular vein. It's typically one side, not the other, and it will back up the fluid flow. So basically all this fluid that's collecting inside the brain, the cerebrospinal fluid, it's trying to get out through the transverse sinus and the jugular vein, and if it can't flow past that point, or if the flow is restricted, then the fluid accumulation on the top end is going to be affected naturally. And this can slow the resorption of cerebrospinal fluid. So the atlas can cause a jugular vein compression. The jugular vein is the main drain of the brain, and it's the primary drainage point of all cerebrospinal fluid that gets collected in the central sagittal sinus. Jugular vein compression and occlusion can cause a backup all the way into the brain, and poor cerebrospinal fluid flow inhibits the glymphatic system of the brain, leading to the accumulation of metabolic waste inside the brain. Now, the glymphatic system, although it's always at work, when we sleep, it's more effective. So the glymphatic system, it's not just that things are washing around. When we sleep, the spaces between the nerves start to open up, and the cerebrospinal fluid is able to pass through and wash out of those spaces a lot of the metabolic waste that's accumulating inside the brain, any toxins, and in the event of a mild traumatic brain injury where there is damage or inflammation inside the brain, it is its only passage back out. So you can start to put the pieces together here. If your brain cannot effectively filter through or collect that gunk from inside the brain, it will accumulate over time. And the more time you have with poor drainage, the greater the accumulation grows, and the faster neurodegeneration occurs. This is where the strong links with these neurodegenerative conditions come in. It's first noticed as just cognitive decline. One of the first symptoms people will say is they feel like they have brain fog. They just can't think very well. Or they'll have pressure in the head because they're not able to get the fluid out as fast as is being produced inside the brain. And so I have pressure behind my eyes, I have pressure inside my head, I have a pounding headache. The pounding is for a reason. It's because there's pressure coming in without it being able to come back out. And then the cognitive decline from the brain fog, that's the next cascade. By the time you get to these neurodegenerative conditions, that's the end stage of the early problem. And so instead of trying to say, hey, let's wait until we can see it on imaging or we can test to see this massive neurological disruption in this person, Alzheimer's, Parkinson's, dementia, things like that, if we can start to identify there's a reason why the brain doesn't function, why it's not clean, why you're not thinking well, you can start to put the pieces together and work your way backwards and evaluate the structures that would influence the ability for the brain to stay clean and healthy and the pressure to stay normal. So it's just working its way backwards, the cascade. So here's one example of hydrocephalus, pretty significant hydrocephalus. Compromised drainage of the cerebrospinal fluid leads to an increased accumulation of the cerebrospinal fluid, leading to possible conditions such as normal pressure hydrocephalus, enlargement of the lateral ventricles like you see here, enlargement of the fourth ventricle, which you do see here as well, turbulent CSF flow, which is definitely going to be present in this case, pressure, headaches, and ocular pressure, which is pressure behind the eyes. These are the common symptoms. Okay. Continuing down, we have the lymphatic system disruption. We've been talking about this already. But this is the flow pattern. Central sagittal sinus. Come on. That's why I hate animations. Takes a long time. I make them, and then as soon as I get to the presentation, I'm like, why did I think that was a good idea? The central sagittal sinus is literally in the dead center of the brain. It goes from the front all the way back to where the main cortex meets the cerebellum. Then your transverse sinus goes left and right and takes a hard right turn, and it becomes the jugular vein draining out of the skull down the front side of the neck. Okay, so that is the flow pattern. It's just a very simple version of it, but that way you can see, okay, I collect here and it drains out. And it should be doing it out of both sides. Think of it like a faucet. So pounding headaches, we talked about that. Location of the turbulence will commonly have a lesion. We talked about that. We talked about this. Man, it's so important I said it twice. Okay. This is the biggest summary of this, though. The craniocervical junction is a choke point for craniocervical hydrodynamics. That's the big takeaway. That you're not moving the bones of the skull very much, but you can move that atlas under the skull quite a bit. And as soon as you disrupt the position of those two bones in relationship to one another, it has the ability to affect quite a few flow patterns through blood vessels and through the actual cerebrospinal fluid that's flowing right down the spinal cord to try to get down to the sacrum and back up. That is the takeaway I really wanted to drive home. Okay, cerebral blood flow insufficiency. So back to this chart. This is our top-down view. Now we're going to be talking about the vertebral arteries. Now, the carotid arteries are very big, very high pressure, closely tucked blood vessels. They do sit in front of the atlas bone, but they're medial enough and there's nothing in front of them that's hard typically. The chance of the carotids being occluded from a misalignment is very low. We rarely see it even in our field, and we deal with this structure all the time. What we see very frequently is vertebral artery insufficiency. The vertebral arteries go through the atlas bone, they come up, and they actually merge to become the basilar artery. So the two become one. The one goes into the circle of Willis. The carotids also dump into the circle of Willis. So How many of you have seen the what is it? The watering ring around like a tree or a bush? When you have your watering system, it'll have an in and out. Sometimes it'll have 2 points to go in, and then it distributes the water evenly around the entire bush, and it just has a bunch of holes in it. You guys have seen that before? No? Okay. What is it called? Like the irrigation systems for landscaping, right? You have those little black tubes, and then when you get to certain bushes or trees, it'll come to a ring, and the water will flow into the ring, but instead of it shooting out, it just has a bunch of holes poked in the bottom, and so it pressurizes the whole ring and evenly waters it on all sides. It's pretty smart, right? The circle of Willis is that in the brain. So even if you don't get blood through 1 or even 2 of those blood vessels, you have some other points of delivery. And so it can still pressurize that whole circle. And then from the circle of Willis, it distributes it again to the rest of the cortex of the brain. This is why a lot of times you'll have a brain stem or a cerebellum blood flow insufficiency, but the main cortex of the brain is still fine. It's because we have this backup system to make sure blood still can get evenly distributed. So most of the time, you're not going to see a blood flow insufficiency into the main part of the brain. You're going to see it a lot lower, and it has very consistent patterns to it. I need a picture of the circle of Willis now, just for you, Greg. Just for you. And that hose. I'm going to get both. Okay. So this is just placing it from top down to where it is positionally here. The vertebral arteries go up through the lateral foramen of the spinous, the transverse foramen of the atlas bone, and then it wraps around and comes up right next to the brainstem. And it also has a branch that drops off pretty low and goes to the backside lower portion of the cerebellum. Okay. So this area is coordination. Main thing cerebellum is going to be dealing with is coordination. So when you have a misalignment of the craniocervical junction, it can cause strain on the vertebral artery as it passes through the transverse foramen of the atlas. This causes a decreased blood flow through the vertebral artery, primarily affecting blood through the pica. That's that posterior inferior cerebellar artery, that back lower part of the cerebellum. And that pico restriction will limit oxygen to the posterior medulla, inferior cerebellum, and vestibular nucleus, affecting balance. Now I'm going to talk about vestibular nucleus in a second, but it's the main integrator of all of our balance functions, and it controls our posture muscles unconsciously, right? If I'm sitting here, or if I'm standing here, and I think about Rocky Road ice cream, I don't just fall over, right? So my posture muscles will stay fully activated no matter what crazy thing I have in my head. My heart will keep beating, my food will keep digesting. And so posture is not a voluntary function. It's not something we're supposed to think about. It's supposed to be 100% involuntary, right? If I said, Greg, if let's say you had a heart murmur, I'm like, Greg, why won't you just try harder? Think about your heart harder so the murmur stops. You'd be like, I can't. Like, that's crazy. You'd be so frustrated at me because it's a completely involuntary function. Posture is, by design, an involuntary system. Ergonomics said you need to voluntarily control that involuntary system. It's kind of weird. So if we can restore blood flow and proper control through the vestibular nucleus, posture is restored autonomically instead of trying really hard to think about it. So once the insufficient vertebral artery merges into the basilar artery, blood for the circle of Willis distributes evenly to the rest of the cerebrum, which is what we said. In some early development of vertebral artery insufficiency, the sufficient artery will cross to the opposite side. Sorry, this is really detailed, Greg, specifically since you were like, who's the audience? No, 20 minutes ago. But for the, no, but no, it's okay. But this is actually really important. When we image the vertebral arteries coming up here, you see how it's nice and thick all the way through, and then it's thinner in general, and then gets almost to a trickle, right? That's a vertebral artery insufficiency. But the basilar artery, which goes from that foramen magnum area straight up to the center part of the brain where the circle of Willis is still sufficient because it's getting enough blood from here. Here's another example. That's a vertebral artery. That's a vertebral artery. That one's insufficient. What needs to be evaluated is that insufficient because it developed smaller when they were a kid? And if it did, you're going to see it small all the way down the neck. Or is it even up to the point where it can be disrupted, and then after that atlas bone, if there's a misalignment and it's putting tension on it, it's nice and even and full, and then one side continues full and the other does not. That would be traumatic. Does that make sense? Okay. So that's very important to distinguish. Are we looking at congenital or traumatic insufficiency? Some of the common symptoms: loss of vision or double vision, dizziness and vertigo, numbness and tingling in the hands and the feet, nausea and vomiting, slurred speech. I spelled slurred speech, slurred. Look at that. Slurred speech. Change in mental status. I'm leaving that just for that. You're not gonna forgive me. Change in mental status, severe sudden weakness, loss of balance, coordination, difficulty swallowing, weakness in parts of the body. The most common is going to be loss of coordination, dizziness, and vertigo. Those are going to be your most common. Okay, moving down. Man, I want to get to the good stuff. Vestibular, like I said, it's an unconscious function. I'm going to do this really simple because this is one of those things. It's like a bee is faster than a John Deere tractor. We're going to go with that version of this, okay? The vestibular system is different than the vestibular apparatus. So depending on what field you're in, when people say you have a vestibular problem, they might be only referring to the inner ear or the entire integrative system. So there's three main inputs to the vestibular system, the neurological center that coordinates this whole thing. It's our eyes, our inner ears, and our proprioceptors. And proprioceptors are like our sensors that give us spatial awareness. So I know my arm is behind me, even though I can't see it, because my proprioceptors are informing my brain of its position. Right? I know I'm wiggling it. I'm not ignorant of that. The eyes give about 5% of the information. The inner ears, even though there's an entire field essentially dedicated to this, like the ENTs are like the ear is it's the crystals and the apparatus in there, it's actually only about 25% of the integrated system. It's about 70% of the information is proprioceptors. And the densest area of proprioceptors in the entire body is in the craniocervical junction from the suboccipital muscles. And it's because it gives us an awareness of how level our head is in space, which affects the positioning of our eyes, of our inner ears, and also how level the brain is to the horizon, which does have an effect on its health. So, right, be as faster than a John Deere tractor. I'm trying to keep it in there, okay? If you have a mismatch of inputs, so let's say you have one disrupted crystal, and it's sending information into this vestibular nucleus, which sits right at the base of the skull and the top of the neck, right around the foramen magnum. If one crystal is saying you're in one spot, the other crystal is properly positioned and it's saying you're in another spot, your eyes are saying one thing and the proprioceptors are still disagreeing with that crystal, the system will go, where am I? I don't actually know where I am right now. If you had eye problems, same thing will occur, but blind people don't fall over. So you can be blind and still have great balance. You cannot have good balance if you have a disruption of the proprioceptors. It's a huge amount of the information. And so anytime you have a mismatch of the inputs, balance goes off. It gives us a sense of disorientation, which we call dizziness or vertigo, right? If we change position and we get vertigo, a lot of times it's because the crystals are disrupted, because it flows the fluid through the inner ear and it starts to activate some of the inner ear nerves that will tell you where you are in space. But if it's not right, the movement until that fluid stops flowing, it will cause you to be disoriented until it comes to a match again, and then you're like, okay, now I'm stable again. But the vestibular nucleus, the output is your posture muscles. So the input is where am I, and the output is this is what I need to do based on where I am. So if I think I'm leaning, I'm going to activate different muscles to pull me back from leaning. But if I'm not actually leaning, it's just that the inputs are wrong, then my posture is going to compensate as an output of the result of what the information was going in. So it's junk in, junk out. Does that make sense? For real? Okay. I just said all that with the far more simple version. But the vestibular dysfunctions, the output will cause postural distortions, balance issues, dizziness, vertigo, visual disturbances, and escalating imbalances. And then when you lose that postural control, you're going to see poor posture, forward head syndrome, neck and back pain, spinal instabilities. And if you leave these imbalances long enough and keep moving on it, it's just going to wear and tear one side more than the other, leading to spinal degenerative disc disease and spinal surgeries is typically the end result. So unless you got a direct injury to the spine and it needs immediate intervention, most of these surgeries are degenerative in nature. The question is, how do you get so degenerated? What drove that imbalance that led you there? Can't believe it. We need like 8 hours. I love this stuff. I know I'm getting really geeky, but I see patients all the time and we don't have every answer. But one of the things we do the best is seek out the root cause of problems and distinguish what's coming from what. Is it congenital? Is it traumatic? Is it from the neck? Is it from other areas? Is it multifaceted or is it a single origin? We're really good at the distinguishing. That's what we spend our time in. And if we can distinguish what's contributing to the problem well enough, the chance of them getting a complete outcome is very high. It's not every time. I wish it was every time, but it's much higher the clearer the roots of the problem are discovered. So that's why I spend time on this, is just saying, look, let's uncover what's making that happen. And if I don't have the answer, I'm going to refer to someone who can ask some really good questions, the ones that I don't know how to ask. I can clearly see there's a problem. I can kind of see what system it's in. I just don't know what question to ask next. And we move them on to the next best person to discover what's going on there too. So that's why I do this, and this is why I like this. So brainstem disafferentation. Afferent nerves are the ones that go from your body into your brain. Efferent nerves are the ones that go from your brain to your body. So disafferentation means improper input, right? So when I see something, it's an input to my brain. When I hear something, it's sensed here, but it's input into my brain. Proprioceptors is where the information about where I am in space into my brain. So if I have bad inputs, then my brain will go, I have no idea what's going on. And then the outputs will be wrong too. That makes sense, right? It's pretty simple. So one of the disafferentations that's really common is when that upper neck gets misaligned, it causes disafferentation into the trigeminal nucleus. In summary, the trigeminal nucleus is the pain center for the head, the face, and the neck. It goes from about the foramen magnum as low as the bottom part of C2 in some people. So it's actually a really long nucleus. It's one of the ones that's most easily affected by a misalignment or a disruption of that upper neck. And so irritation of these nerves, they'll cause pain in various areas of the head, the face, and the neck. This is also why people can have trigeminal neuralgia, and the problem might not be where the pain is. They're feeling lightning in their face, and it could be coming from the neck. But they're getting all these procedures done on the areas that hurt and maybe not tracing it all the way back. So sometimes when you clean up the input, the output cleans up too, and this is what causes a big reduction of headaches and migraines and facial pain, especially in mTBIs. It's one of the quickest symptoms to resolve with work on the craniocervical junction, but it's also one of the longest standing symptoms known in this world. Like, what's the most persistent symptom? Headaches. Almost uncontested that headaches are the most consistent, but it's because of that. Just because you got whacked in the head doesn't mean that's the origin of the pain that you're feeling. Okay. Greater occipital nerve comes out right under the atlas bone, and it's the nerve that wraps up and around the head. So if you have irritation on that nerve, you'll have headaches starting from the back going forward. Okay. This is an 1.5-hour class. Let me do it. We're doing John Deere tractor version. Give me 1 second. Okay. What's that? Oh, you good?
Asking what he does for balance. That just.
Oh, I'll
do anything.
no, it's a okay.
Easy stuff.
So this is so interesting. I'm doing the Farmer Simple version because this really is something that needs to be unpacked. I probably will do a separate class on this specifically, but it is very common for someone who has a mild traumatic brain injury to be stuck in fight or flight. Right? It's very well known at this point. However, a lot of the direct interventions on the sympathetics are pharmaceutical or therapeutic, like mental health type therapies. It's not all of them, you see reductions in it with even something as basic as hyperbarics, right? That drops down. This is one unknown though that I find really interesting, and it makes a lot of sense why soldiers who have been military personnel who have been in blast injuries come back with very, very strong sympathetic tones, sympathetic dysautonomias, and PTSD. Right. And this question eluded me for a long time, and I had to dig. So I'm giving you the really simple version, and we'll dive deeper later. But the afferent, so from the body to the brain, the afferent signals from the suboccipital muscles, the proprioceptors, they actually have projections into the vestibular nucleus and the cerebellum that piggyback and go straight up into the limbic system of the brain, and they'll affect the amygdala and the hypothalamus, and they will set the tone of the brain into a sympathetic tone instead of parasympathetic. And this person will be driven into a sympathetic dysautonomia regardless of the situation that they're encountering. So if I am stressed out because I have something coming up, or Jerry decides to like violently attack me, then I'm going to go into a fight or flight, which would be the right response in that scenario. And then once that situation is resolved, my body should drop back into parasympathetics. A person that has this going on, being driven from a structural problem that's forcing the brain into it, they could be in Tahiti on the beach, and their body is responding like they're being attacked by the bear, but like some bear in the woods or something like that. I've had multiple mTBIs. This was going on with me last night. When I go out of alignment, one of my most common symptoms is I will go into fight or flight. My heart was beating out of my chest. I could barely sleep last night, and I was getting ready for this presentation. So at first I was like, man, I'm really feeling the pressure. I'm like, hold on a second. This is like way beyond that. And I mean, I came in, she could see it in my eyes. Right. I'm like, I have got to get corrected. I got to adjust it. It took about 2 minutes, and I came all the way down into parasympathetic. My heart was calm and my thoughts were super clear. And the reason why they cleared up is because when you get into a sympathetic dysautonomia, it increases stress hormone. So adrenaline or epinephrine, if left long enough, cortisol is going to be rampant. Increased muscle tone. I was feeling every single one of these. Increased heart rate and blood pressure, reflex responses, increased adrenaline, which is like jet fuel to every one of these responses, basically. It increases your energy expenditure. So you're burning all this energy without anywhere to put it. and it depletes your reserves. You don't put anything into the tank. And so that's why you end up with adrenal fatigue. You're just burn, crash. You'll burn through if you need to fight a bear. Like, yeah, you better be full blown, full power, like mama bear strength kind of thing. But you will burn out when this is done. But if it never turns off, you are in chronic fatigue. You're just stuck there. And it's going to decrease your immune system response, your digestion. I always joke around, a bear will kill you faster than a bacteria every time. So being in a sympathetic tone for 5 minutes to run away from a bear, I mean, you could be heavily infected with bacteria. The bacteria is not going to kill you faster than that bear will if it gets a hold of you. So your immune system is irrelevant in a life-threatening situation. You can worry about the bacteria once you're out of the life-threatening situation. Digestion goes down, the absorption of your food goes down, decreased peeing and pooping. Your healing responses go down, so you heal a lot slower, and it depletes your cognitive function, drains a lot of the brain activity away from the frontal cortex all into your primitive parts of your brain so that you can survive. It's all survival at that point. So if you had a sibling that jumped out and scared you, like, ooh, do this algebra problem real quick, you'd be like, I literally can't right now, because your cognitive function is tanked until you come out of the sympathetic tone. That's where a lot of people are living, though. That's their everyday.
High anxiety.
High anxiety. So if left long enough, because we're seeing all of this is coming from sympathetic dysautonomia, it's going to lead to a chronic fight or flight state, chronic stress and anxiety, chronic fatigue and adrenal fatigue, sleep disturbances and insomnia, hormone imbalances, PTSD, mental health issues. And if you can't escape that jail, you find your own escape. I had two friends commit suicide in the military, and I didn't understand why. And I don't even know if it was mTBI related, but it made me really question why we had such high rates. And I'm like, something's wrong here. I'm like, what are they trying to escape from? Like, where's the bear? And then when I started to understand this, I'm like, oh my gosh, they don't hate life. They hate life feeling like this. I don't tell many people this, but I remember two of my friends committed suicide. I remember the day I walked out beside my tent. I was like depressed when I was overseas. I got so depressed, I couldn't feel my skin. It was 130 degrees out, right? There was a sandstorm coming. It was whipping against my face. I felt nothing. I was numb emotionally so much that I couldn't literally feel my body at all. And I stood there like sun blazing down on me, and I go, I get it. Like, I rationalized suicide. I didn't want to kill myself, but I'm like, living like this is worse than dying and feeling at least something. Right? It was weird. And I stayed in that place for like a month. I wasn't like suicidal, but man, I was like, I get it. I get why they want to do that. It's not that they didn't want to live. They didn't want to live feeling nothing, feeling trapped. And the trap is your own skin. Where's the escape?
That was God right there, preparing you to help.
So for me, I look at this and I'm like, if somebody had no stress and anxiety, no chronic fatigue, great sleep, right? Their hormones were working fine, absolutely no PTSD, feeling amazing, working out, high energy, thinking super clearly, pursuing their dreams, or they're just going to be like, I want to end this. I want out. It's weird to think. So instead of looking at it as, hey, we need to reduce suicide, maybe we need to look at it as what's driving the prison they're living in. Get them out of prison. It's like jailbreak. Okay? That's the chart. We did it. Okay? So my whole point in going through this, obviously there's blast injury involvements. This chart is going to include axonal shearing injuries and things like that, and some of those cascades, chemical imbalances that come from that, and the disruptions. My point is to introduce a very seldom talked about topic in mTBI in an area that's very commonly injured and very commonly overlooked, to help explain why we might have some of these symptoms. So my recommendation for this is based on The research behind it, obviously we're going to do a longer version that's going to involve a lot of the white papers, and we'll take our time going through each one of these topics and show the white papers, but I just wanted to give you this broad view of the potential effects of craniocervical involvement in the symptoms that we see in mTBI very commonly in both the small ones and the big ones. So if this is getting injured, we need to be able to evaluate it, and we need to be able to see what might be a part of it. So instead of just saying, hey, let's scrap the playbook, this is what I suggest we include in some of our diagnostics. So they're very simple, and obviously we can take a much deeper look, like craniocervical specialists. There would be the diplomate in chiropractic craniocervical junction procedures. We evaluate a lot of these autonomic functions in various ways, but there's a couple that I would definitely suggest that clinics and physicians can add in and start to see if a picture is painted that there might be some neck involvement with an mTBI. So Fukuda's stepping test, this test is where your eyes are closed, you march in place for 30 seconds, right? Just like this. And if the patient starts going off center, when you're doing that stepping test, it's actually checking the afferents into the vestibular system. But you're closing your eyes, so you're cutting that input out. And the ears are typically activated with head movement. So if you're staying still and just moving your body, the primary input is proprioceptors. And if they can't stay in place, there may be some proprioceptive involvement in the vestibular system, which is here. It should be correlated with one or two other things, right? Just because you see one positive doesn't mean you should go, there it is, right? Can I reproduce it? So there's a couple other things we can do. Supine leg check is a very well tested orthopedic test, but if you have a patient with a head flexed a little bit, like on a soft pillow, it isolates the neck as the primary involvement to what we see in the supine leg check. And so if you see one leg is shorter than the other, like a quarter inch or more, and then you have the patient turn their head, so you're changing one variable, turn their head, which will change the proprioceptive input from the craniocervical junction mostly. And if you see the leg length change, that's actually an indicator that the proprioceptive problem is coming from the biomechanics of the upper neck. So adding that one variable actually starts to distinguish what we're seeing and why we're seeing it. Cervicogenic shoulder strength test. Basically, you can have the patient laying on their back with their hands straight up, push their hand down, test both sides, right? But just push your hand down, try to use equal strength. If one side is a lot weaker, take the weak arm, have them turn their head, test it again, turn their head the other way. So again, you're changing one variable. And if it gets stronger and weaker based on the way they turn their head, you could do it 3-4 times to make sure you're seeing what you think you're seeing. Again, that's letting us know that there's some output coming from the neck that's driving it. And the main thing you're moving when you turn your head is not the lower cervicals, it's upper cervical. It's that C1, C2 rotation. And then postural observation alone doesn't mean a lot, but if you see tilted head, crooked shoulders, and you've had one or two positives here, the picture's starting to get a little clearer. So correlation is so important to make sure that we're barking up the right tree. Even if there's a suspicion, I would definitely have them be evaluated. Now, when it comes to, additional testing, you could do some pursuits, saccades, optokinetics, some functional neurology to see what's going on with the eyes. And you can, again, do some input-output testing to see if it's cervicogenic or not. Sometimes it's only in the eyes, sometimes it's coming from the neck. But the eye movement is heavily influenced by what's going on with proprioceptors here. I won't go into too much detail today. If they also have the common craniocervical syndrome symptoms, especially more than one, if you're seeing 3 or 4 of these, you think of it like a constellation, right? You got a star over here, a star over here, a star over here. But when you take a step back, you're like, oh, that's like a crab, right? It's a constellation of symptoms that are related. And when you see more than one of these, there's convergence points that would drive multiple symptoms like that together. That's why the correlation matters so much. If I have just a headache and no other symptom, I'd be like, huh, this will be fun, you know? If I'm seeing headaches, dizziness, brain fog, and pressure in the head, I'm like, come on, like there's not many places that are going to cause that group of symptoms together. CCJ imaging, these are recommendations, but craniocervical x-rays or cone beam CT, they're used to measure the craniocervical junction. It measures the shapes of the bones and where they're positioned in relationship to one another, and it helps us get vectors, basically angles, to correct them on accurately. MRIs have been critiqued pretty hard as like plain MRIs as unhelpful, essentially, unless you can see actual brain damage. And so most of the time you just do a plain brain MRI, you're just going to go, nothing there. Now, obviously, imaging is advancing very quickly. We have a lot of them. I'm not reviewing all of the imaging. These are additional recommendations to what's already growing in the mTBI field. But if you do upright MRIs, upright is so important because it allows all the nerve structures to lay as low as they're going to and create maximum occlusion on the hydrodynamics. So if you go recumbent, the brain rises and it'll actually open up a lot of pathways. If you throw them upright, sometimes those will descend low enough, especially if they have like a Chiari malformation or a cerebellar tonsillar atopia, and you'll see the full effect it's having on that person, and it'll explain a lot more. So sometimes it's missed if it's not upright, but it should go down through the craniocervical junction. Some imaging centers have ALAR protocols. It's close, but we can even work with the imaging centers and develop super specific ones that will slice through the ligaments that we're trying to evaluate to see if there's any instability or disruption. So expanding, I'm simply saying go 2 inches lower with thin slice brain quality MRIs. 2 inches lower and you go, whoa, that's going on, that's going on, that's going on. I see it all the time. Report says brain is fine. I'm like, for real? I'm like 8 feet away. I see 4 things. But we're looking at it from a different lens, okay? The contributions to the brain, not just whether or not the brain was damaged. So definitely down to C2 from the brain. And then Cine MRI is the most fascinating. Can it play? Yes. Have you guys seen this? Have you seen it? Yes, okay. Cine MRI is fascinating. We just had a guy here, a tech that knows how to do this, move to South Tampa. I'm going to talk to you about this, by the way. It shows the flow pattern of the cerebrospinal fluid in its pulsatile fashion. You can start to see, and they even now they're getting velocity readings so that you can see where there's turbulent patterns. But what we're looking at is the flow pattern, and if you know that there should be an open flow pattern and you see areas of disruption and no flow past that, you are literally watching why the brain's breaking down. This is so key. And again, it's in conjunction with the other imaging that we're also doing, but it is amazing. So lastly, intervention, right? What additional thing can we do for a mild traumatic brain injury? So this is just an image of us taking some of the upright x-rays. We take it from 3 separate dimensions. Our field is moving into cone beam CT as a gold standard. Very soon it's going to be the gold standard for upper cervical specialists. But we're evaluating the bone structure and the alignment of those bones in relationship to one another. That actually gives us vectors. So we can adjust in a very specific way on specific angles using table-mounted instruments, which reduce a huge amount of variables. And so the way that we're angling the instrument to the person is based on the way it's misaligned. So if we know it's gone one direction definitively and measurably, then we can adjust them with the reverse vector to shift it back into its proper position, which would open up all these pathways, the hydrodynamics, the afferentation into the brain, the space where the brainstem is sitting. We start to improve the entire functional space of the craniocervical junction. This is an up close of the one we use. It's called advanced orthogonal. It uses a percussive sound wave. Think of it like a sonic hammer or a pulse that comes off the end of it, and we're using the percussive quality and force behind sound to shift the bone under the skin. Basically, it's nearly imperceptible to the patient, and it's very, very safe. Okay. So some of the benefits of that precision approach, we're able to do neutral positioning adjusting, right? Remember how I was saying, if you already have some instability in the craniocervical junction, you don't want to maximally rotate or thrust hard in an unstable or currently damaged structure. So because we're adjusting in a neutral position, it eliminates additional strain on those craniocervical ligaments. We're able to deal with very severe cases very safely. Calculated vectors are really important. So because there's specific imaging that is analyzed to determine the exact position of the ligaments or of the misalignment, the directional force of the adjustment can also be calculated. So we know where it went, we know where it needs to go, and we can reverse engineer the exact way we need to adjust them to get there. Low force adjusting, so the percussive sound of adjusting and similar techniques, there are a few of them that are very low force adjusting. They allow for minimal adjusting force with maximum brain health impact. And then post-adjustment evaluation and measurement. So after the initial correction, we actually do neurological tests we reassess them to make sure that we saw neurological changes in those main systems that we first evaluated. And then we also take post-adjustment X-rays or CBCT to evaluate the structural alignment change. So this allows for precise modifications to be made to the adjusting vectors for future corrections to increase precision. Basically, if we measure it, we adjust it with the calculated vectors, and it doesn't respond the way we were hoping it would, we can modify it based on the way we saw it respond and get more accurate on the follow-up ones. And then lastly, I think this is one of the most important, is that there's standards of care to this type of work. So it's not the chiropractic field in general, and I actually like that it's getting siloed out for some of the more specific work. But when it comes to the upper cervical techniques, they're vetted by the International Chiropractic Association's Council on Upper Cervical Care, and that council also runs a 3-year postgraduate program called the Diplomate in Chiropractic Craniocervical Junction Procedures, and it has options for fellowship as well. So I am a DCCJP, I'm a diplomate, and I'm going for fellowship this upcoming year. But because of that, this group of people, everything I've been presenting today, they have a very keen understanding and they're very careful. And so they know how to deal with a category of cases that normally you wouldn't want someone just haphazardly working on. I'm not saying that they're not skilled people, but it is the difference between just saying it can help and this one will and this one won't and this one will and this one won't, and being able to distinguish it in different cases. And I like that because it just guards a little bit of the outcomes and the expectation of those outcomes. And we want to get as many people trained in this work, whether they do it only or included in their other therapies. I really like it. So this, again, it's just the big summary, the working model for the pathophysiological injury cascade for mild traumatic brain injury, including the involvement of craniocervical junction injuries and contributions to why the brain breaks down. It's going to modify a little bit, but this is my 12-year baby. So I really appreciate your time. I think that's it. Oh yeah, real quick, right? When we first started, I said policy has to match the physiology. So if we want to keep moving the field in the right direction, we have to understand the full gamut of the physiology and pathophysiology that's involved with the mild traumatic brain injury. The physiology, like what happened in that case, should determine the treatment. It should point us like that treatment makes sense, that one doesn't, that one does in this case. This other case over here, this one matches, that other one that matched on here does not match on this case, right? And we can start to distinguish, hey, we're getting more and more confident. We know we're going to get outcomes because it's matching the physiology. We trace it to its root. This one is direct damage to the brain. This one is not. We're throwing our hands up, but we saw craniocervical involvement. Now we know what we need to do here. And so, this is just some suggestions, but immediate intervention, this is not complete. not complete. But hyperbarics have proven amazing for everything from immediate intervention all the way to late stage intervention. Very consistent all the way through. So you can see the earlier treatment would still be relevant in late stage treatments. What I find though is sometimes people say, well, it worked over here, so it should be done here. I don't necessarily agree with that. I think if we can get maximum results with minimal intervention, we do the minimal thing necessary to shut down that person from continuing down the cascade. And if we can just shut off whatever's contributing to it, we should be able to look at that person and go, you're going to have a good life. Not, we'll just sit around, watch and wait and hope it doesn't get bad from here. I want people to get well, and I want their brains to work, and I want them to have a good life. My heart's definitely in the military, but I've worked in the sports world. I don't care who it is. I just want this situation, this problem of mild traumatic brain injury solved. And I think the more we collaborate and the more we work together and the more we try and wrestle with where things go based on what's happening in the body, we're going to come up with amazing protocols that, like clockwork, are just turning brains back on and shutting down these problems. I'm confident of that, and I think this is something we can do. So policy must match physiology. And then this is going to be the hardest one, guys. Changing the culture of sports, the culture of the military, the culture of the places that are getting these mTBIs the most. Getting them to understand you cannot sit around and watch these people decline. We'll help you, we'll work with you, but you have got to shift your culture to support the policy that's in tandem with the physiology and the treatments that match the physiology too. That's when we really make change. So, thank you so much, guys, for your time. I appreciate it.